You're very welcome to this video, and I'm going to start off by reporting on what's called the Siren study. Now, this is a study of nearly 21,000 healthcare professionals throughout the United Kingdom, looking at who got infected in the first wave and how likely they were to be reinfected in the second wave. Now, this study concludes they get at least 5 months protection in terms of antibody cover, but as we know, there's other things provide longer term immunity than that, but that study doesn't comment on this particularly. What it says is protection here is lasting for at least 5 months, but we believe it's longer. But this is what this study is showing. And it's also showing that people who are naturally infected are 83% less likely to get another infection than people who weren't infected. In other words, it's actually saying some of the vaccines with 95% efficacy actually give more protection than the natural protection, which they're saying is 83%. But when you actually look at the actual number that were reinfected, of all the people that had the infection the first time, reinfection only occurred in 0.66%. So well less than 1 in 100 of people who had the infection before got the infection again. 0.66%. It's getting on for 1 in 200, isn't it, who got reinfected. So looking good there in terms of reinfection. And the people that were reinfected, this 0.66 minority that were reinfected, they didn't seem to get very ill, and they certainly weren't as symptomatic as they were the first time round. But, and it's an important but, they were still infectious. So even though it was only 0.66%, the ones that did get reinfected were still infectious, even though they themselves were not sick, but they could potentially pass it on to other people. So that's kind of the bottom line from this study, really. Let's look at it in detail now, but if you need to skip now, you can do. Later on in the video, I want to talk about this World Health Organization team to China, and I want to talk about Lebanon, and we'll see how we go for time. Things are very bad in Lebanon. It's an example of where there's been so many infections. The healthcare providers are completely overwhelmed, which is what we've been worried about since the start of this study. But anyway, details on the Siren study first. Very useful study, very interesting. So past COVID-19 infection provides some immunity, but people may still carry transmission of the virus. Now, this is published 14th of January, which is today. UK government publication. Now, it's Public Health England, and this is called the Siren study. Now, it's one of these sort of acronym ones where you've got to sort of do a bit of a limbo dance to see what it means. But we'll, for the sake of completeness, S I R E N, SARS coronavirus 2 immunity and reinfection evaluation. So that's where they get the Siren from. It seems absolutely obligatory these days that every significant trial has to have some sort of catchy name, and this one's the Siren trial. So there you go. Straining a bit much out of the tea bag perhaps, but that's what it's called. Now, this is the official report from the Public Health England, and this is the preprint of it. Now, important to note, this is not peer-reviewed yet, but it is a report from Public Health England. So we're kind of dealing at a press release level of science here, but it's Public Health England. It's based on a good study, reputable academics behind it, but important to note it is not yet peer-reviewed. It will be, of course, and let's hope the peer review actually makes it a bit harder to read, because it is a bit hard to work out what they're saying some of the time. But I think I've got it sus, so we'll share that now. So since June, it started in June, 102 National Health Service trusts, so all over the country. Regular antibody testing and preliminary chain reaction testing, that's the antigen testing for the virus, as you know. And they've done 20,778 healthcare workers. So good sample size. They've been followed up for a while. I've obviously got friends and colleagues on this trial, so I have been following it with some interest. And I've been awaiting this outcome with some interest as well, it has to be said. Now, of that nearly 20,787, 6,614 tested positive. So these are the amount of people that they're following up. These are the ones that they got a positive test from any time in the study. So they're the people that had the infection, we are assuming. Now, what were the results? So it's good sample size. We've got 20,000 altogether. 6,614 healthcare workers actually had the infection in 2020. Results. Past coronavirus COVID-19 infection provides some immunity, they're saying. Well, they're saying some. This is very conservative. It actually provides a fair amount. This is written in very reserved scientific language, but as I say, it is a press release, really, so quite what we can get in absolute terms. But they're saying some immunity, but it's looking like quite a lot, actually. They're saying antibody studies last for at least 5 months. Now, this is what we know. We know this already. We know the antibodies don't last for long, but when the antibodies are there, especially the neutralizing antibodies that will cover the infective spike protein of the virus, that's going to confer immunity. And to be perfectly fair to this study, in the full write-up, in the preprint, they were fully aware of things like T-cell immunity, and that is currently being studied, but not a lot of data on that yet. Where have I gone? There we are. But this is important to note, people may still carry and transmit the virus. Now, as we said, only 0.66% were reinfected, but those that were still had high viral loads in their upper airway, their nose and their oropharynx, and were shedding a lot of virus, so were still infectious, even though they didn't become highly symptomatic themselves. So this is an important point to realise. May still be able to carry the virus in their nose and throat, even though it was a small minority. Therefore, from this small minority, there is a risk of transmission. Now, new COVID-19 infections and antibodies, nothing to do with the vaccine. So this study was looking at new COVID-19 infections and antibodies study. So it was looking for the presence of the virus, to some extent the presence of symptoms, and the presence of the antibodies. And they stress it's nothing to do with the immunity that you get from vaccines. So this data is all about natural immunity. They say you cannot extrapolate from this to the vaccination programme, although we might be tempted to do so as we go along, being a bit naughty. So it's about naturally acquired immunity. So they're saying provides 83% protection against reinfection compared to people who have not had the disease before. Now, this is exactly what we did with what the researchers did with the vaccinated groups, wasn't they? They had a placebo group who weren't giving the vaccine. They had a group who were given the vaccine, the experimental group, and they compared the two. And of course, they found out that the infections in the control group were higher than the infections in the vaccinated group, demonstrating the efficacy of the vaccine. Well, this is just the same, only it's people who've actually had the infection as opposed to people who haven't had the infection, and they found out there was an 83% difference in this group, according to that data. So they're saying 83% protection, and we do notice in passing not quite as good as some of the vaccines, although we're not allowed to do that because there's nothing to do with the vaccine. Compared to people who've not had the disease before, fair enough. Lasting for at least 5 months from becoming sick. So from the first day someone's sick, counting as that as day one, lasting for 5 months. But this is an ongoing study. So more data will come, and hopefully they'll come back in 5 months' time and say, you know what, the immunity's lasted for 10 months. And hopefully they'll come back in 2 years' time and say, you know what, the immunity's lasted for 2 years. I think they will, but of course we don't know because the time has simply not yet elapsed. So we don't know for sure. People infected in the first wave may now be vulnerable to catching the virus again. This is true, but only 0.66% of them. So I'm actually fairly encouraged by the level of immunity that the infection gives, and the fact that the very small minority who did get reinfected weren't getting sick. So this is encouraging. And of course, it's the same with the first dose of the vaccine. With the Oxford vaccine, still as far as we know, anyone who's had the first dose of the vaccine has not been hospitalised. So that's sounding very good, but we're not supposed to talk about vaccines today. This is about natural immunity, so let's stick to the point. 18th to the 24th of November, data was collected. Now, the number who had tested positive for antibodies in that time was, as we said, 6,614 were tested positive. So 6,000 out of the 21,000 healthcare workers, nearly 21,000 healthcare workers, 6,614 had been exposed to the virus to such a degree that they developed antibodies. Now, they were a bit circumspect about this. They said 44 detected potential infections. So 44 potential infections, 2 probable and 42 possible is what they are saying. Now, I know this is a bit vague, but they do comment on this in a minute. So the 2 probable infections reported symptoms during the first wave, but were not tested at the time. So that was kind of a symptomatic diagnosis for those 2. But the other 42 that they're describing as possible were diagnosed with the antibodies. Now, to me, I would have put it the other way around. I would say that the ones that were diagnosed with the antibodies, it's more likely to be a confirmed infection, but who am I to argue with the authors of this study? That's what they're saying. But basically they're saying 44 people basically probably were reinfected from this group of 6,614. So that's where we get the 0.66% from. So 44 is that percentage of 6,614. So that's where we get that from. Now, 42 possible cases were diagnosed only by antibodies, as we've said. But basically, if we say that there was 44 reinfections, then that is kind of about right in the second wave. None of the 44 potential reinfection cases were PCR tested during the first wave. So, yeah, a limitation, but it's not really, because the testing during the first wave was very limited. We know during the first wave, or we estimate during the first wave, it was about a factor of 50. So there was actually 50 times more infections than were coming up on positive tests, because the testing wasn't well organised then and well established. But all tested positive for COVID-19 antibodies at some point during the recruitment of the study. So to me, if they were diagnosed with antibodies, that means they've had the infection. I don't see where else they'd get it from. So I'm very happy to go with this number of 44 people who were reinfected. So fairly small number, given that we're talking well over 6,500 people who had a first infection. And of course, remember, these are healthcare workers. These are exposed to infection on a daily basis. You could argue that these are the people in the country that are the most likely people to be reinfected. There again, the age distribution, of course, because they're healthcare workers, they're in the working age population, and often at the younger end of that working age population. But nevertheless, let's carry on. Previous infection group, so as we know, 6,614. Of those, 44 got infections. That gives us a reinfection rate, as we've said, of 0.66%. And of that 44, 30% were symptomatic, meaning that 70% were picked up via antigen or antibody testing. And the ones that were symptomatic were minimally symptomatic. They weren't getting sick or hospitalised. Although, to be fair, the study doesn't give great detail on that. So that was the previous infection group. Now, no previous infection. So remember, we started off with, what did we start off with? 20,778. So that means that that many were previously infected. This many were not previously infected, therefore. And the ones that weren't previously infected, in the second wave, they had 318 infections. That gives them an infection rate of 2.24%. So we see in the second wave, with 2 groups taking all the usual precautions, the ones that were infected the first time, 0.66%, got reinfected. In the group that had no previous infection, 2.24% were infected for the first time. So, and in this group, 78% were symptomatic. So of these, 78% were symptomatic. So 78% of the 318 were symptomatic, whereas in this group that had been previously infected, 30% of the 44 were symptomatic. So we see protection against symptoms as well, which is the main point. And the difference here, even although the reinfection rate was remarkably small, the difference computes at an 83% rate protection. So this is a direct quote from the study. This represents an 83% rate of protection from reinfection compared to those that weren't infected the first time. And if the 2 probable infections were confirmed, the rate would be 99%, but that's, I don't think, I'm happy with the antibody diagnosis, so I think we'll just ignore that bit, because the antibody diagnosis to me is pretty definitive, so I'm happy to go with that 44. Both patients involved reported that their symptoms were less severe the second time from that group. So as with others, if they were symptomatic, which not many were, their symptoms were less severe. So the group say conservatively some protection from becoming ill with COVID-19. They're saying some. It's more than that. It's not a particularly well written press release statement. We'll give evidence that it's more than that in a minute. So protection against becoming ill, only 0.66% became reinfected. And this is actually consistent with what we thought. We always thought the reinfection rate would be pretty low, and 0.66% is a low reinfection rate. Some reinfections carry high levels of the virus and so could continue to transmit. So this is the point. So we don't know how many of that 0.66% had high viral loads, but some of them did. Therefore, they could continue to transmit. So everyone must continue to follow the rules for the immediate future. So this has no, in a sense, this doesn't have an immediate practical application. It mustn't change people's behaviour. So I'm encouraged by that. 0.66% got reinfected and an 83% protection compared to people that weren't infected the first time in people that were infected the first time. 83% protection. 0.66% reinfection rate are the takeaway numbers there. Now, the lead of this study, Professor Susan Hopkins, direct quotes, we know that most of those who have had the virus and developed antibodies are protected from reinfection. So the vast majority are, it's 99.4% or something, because only 0.66% were reinfected. So the vast majority are protected. Over 99% are protected from this data. But this is not total, and we do not yet know how long protection lasts. No one knows that. But as I've said repeatedly, I'm optimistic because the SARS coronavirus, one which is the most similar virus, people are still immune to that 17 and 18 years later. So I'm optimistic for longer term protection, but she's correctly saying we simply don't know because the time has not elapsed. So she's completely correct. Crucially, we believe that people may still be able to pass on the virus. This is such an important point because there can be no behavioural change. So people could be asymptomatically infected, for example, and still pass on the virus. Sorry, asymptomatically reinfected and still pass on the virus. She says you can be reassured it is highly unlikely you will develop severe infections if you've had it the first time. Highly unlikely. Now, we don't know if any of these patients were sick or hospitalised, but we believe not. So she's saying it's highly unlikely you will develop severe infections. In other words, it's very similar to having the first dose of the vaccine, where you might be infected, but you're very unlikely to get sick. Although I keep forgetting we're not supposed to compare it to the vaccines. But it is very likely. It is very like that. There is still a risk that you could acquire an infection and transmit to others, so that has to be remembered. Now, even more so, it is vital that we stay at home to protect our health services and save lives, because we are, as she correctly says, as of the 14th of January, in a dire situation. Now, there is a proviso to this study, because this data, of course, was collected before the new variant became so prevalent. In fact, the new variant basically wasn't circulating. So it's prior to the variant of concern, VOC, 2020, 12, discovered in the year 2020, the month 12, and it was the first variant discovered. And it's what is called B117 very often in the United States. We have wrongly called it, well, it has been called the Kent variant, the UK variant, although there's now evidence that it was in Italy before that, but that's a separate story. It was first detected in the UK. So they're, of course, the team are fully aware of this current lab work. To what extent do antibodies also provide protection against this variant? And we expect it to be good because of the polyvalent nature of the antibody response. What we mean is when someone has the actual infection, they're going to produce a very wide range of antibodies to different parts of the viral structure of the virus, to the protein structure of the virus. And therefore, we expect immunity to still be functional. And as well as that, there's the T cells and all the other immune cells as well that we also expect to demonstrate full cross-immunity with the new variant of concern. Future analysis, impact of the new variant on symptomatic and asymptomatic infections in healthcare workers. So they know about this and they are carrying that on because this study is ongoing. So there we go. Some, I think pretty good news really. 0.66% got reinfected. That's pretty good. And they weren't getting sick, therefore they can't relax. But they because they have to follow the same behaviour as everyone else because they could be reinfectious or reinfect other people. But there again, they can have some reassurance that they themselves will not get very ill or very, very, very unlikely to get very ill with reinfection. So I thought that was worth spending a bit of time on. I hope that made sense. I did say all that right, surprisingly enough. So if you haven't quite got it, listen again. But basically, that is encouraging. And the study is ongoing, and I am still optimistic for longer term immunity. Now, just a couple of other quick items in the news today. The World Health Organization team. World Health Organization team of 10 has arrived in Wuhan as far as we know. Don't hold your breath. They're quarantining in their hotel for the next 14 days. Let's hope they're being supplied with excellent, open, good quality data so they can start their work. Let's hope for that. Now, this is after really, I mean, dear me, it's been a bit farcical, really. Months of negotiations between the WHO and Beijing. Now, the WHO and Beijing normally get on, of course, but it's still been a struggle between those. Now, they're going to interview research institutes, hospitals, and market workers. The article I've read here from the BBC doesn't say they'll be going around collecting samples. They're virologists. I flipping well hope they do go around collecting samples. But it doesn't actually say that. 2 weeks quarantine first. They're going to... Now, the news I've got says they're going to rely on samples and evidence provided by the Chinese officials. So this is implying, as I've just hoped for, they're not actually going to go around collecting their own samples. They're going to rely on samples and evidence provided by the Chinese officials. I mean, if this is the case, why have they gone to China? Why don't they just sit in a lab in New York and open boxes from China if everything they're going to be given is provided by the Chinese officials? This bloke, Peter Ben Embark, seems to be in charge of the team. Now, he says it could be a very long journey before we get a full understanding of what's happening. I think this is what is in the trade is called downplaying expectations. I don't think we will have clear answers after this initial mission, but we'll be on the way. Will we really, Peter? I do hope so. And the Chinese seem to be intimating at the moment that Wuhan is not necessarily the place where the virus originated, even though I think the rest of the world thinks it is where the virus originated, in or near. So that's the World Health Organization team. I'm not holding my breath, and I will leave you to make your own conclusions about how likely that is to be successful. Now, we haven't really got time to cover a lot of countries in detail today. Cases are still going up in the States. There is quite a lot of signs that the new cases are levelling off in the UK. Still at a high level, but levelling off, as we looked at yesterday. But things seem to be pretty bad in Lebanon. Now, your heart just has to go out to the people of Lebanon, really. I mean, I've watched reports of wars in Lebanon basically for as long as I can remember. Terrible problems there, factional problems, external problems, civil war. And then, of course, that terrible explosion with was it thousands of tons of fertilizer or whatever it was, blew up. Anyway, terrible situation, difficulties in Lebanon. And, of course, economically, it's absolutely on its knees economically. So this is kind of the increasing cases here. So sharp increase. And basically what's happening is the government of Lebanon has imposed a complete lockdown, the most complete lockdown perhaps outside of China, for the next 11 days. Complete lockdown, curfew. Schools, restaurants, supermarkets closed. Wow, supermarkets closed. Only deliveries. allowed. Healthcare system is reported to be currently overwhelmed. Now, this is just, well, it's quite upsetting, really. What it means is people will be requiring healthcare who won't be getting it because the healthcare system is overwhelmed. Therefore, people will be dying who could have been saved. This seems to be the current situation in Lebanon. Not only that, it's estimated that about almost half of the population don't have enough cash to buy food until the end of the lockdown period. So it looks like getting on for 50% of the population of Lebanon don't have enough cash to pay for their supermarket deliveries over the next 11 days. And, well, what's going to happen? Are they going to go without food because they can't go out to work for 11 days? You know, so many people around the world eat that night what they earn that day, and an 11-day lockdown. Let's hope these groupings are taken care of. It's a frightening situation. Importation of medical supplies very, very limited because of the economic difficulties, and there's no question deaths are going to rise in the coming days. Purely because the healthcare system is overwhelmed, and then the knock-on effects of things like some people not being able to afford to buy food. Right, so that's that. I'm just going to give a quick message to this World Health Organization team in Wuhan. There's my message, team. Do hope you're watching. That's the message to everyone who want to know this. That's us for today. Now, I got an email from Carly. You might remember Carly's the nurse we've kindly interviewed on the channel. She's kind of come on the channel a couple of times. And she was a bit pleased with herself, and rightly so, I must say, because she's been vaccinated for the second time. Pfizer jab, I think. Now, Carly's due to email me back today to tell us how she's feeling after the second jab. She has booked a couple of days off work, which makes sense, but wonderful to know that frontline workers in the United States are getting, some are getting their second dose now. So really good news. I'm absolutely delighted and incredibly jealous, as I haven't had a first dose yet, but there you go. But I'm delighted, Carly. It's fantastic. Nice red sticker, draw attention to it, absolutely. Is this on the way there or the way back? You don't say. Probably on the way back. This is just getting the jab by the looks of it. So looking good. Now, this is the message that Carly played us in the car after her first jab. I'm not going to play that now because we played that in a previous video. But basically she was very, very, very relieved to have the first jab. And of course, that is a 100% appropriate emotion. I don't think this worked out very well, but this is her actually getting the jab. Can we see? Not quite. There you go. Anyway, she's getting the jab. High in the deltoid muscle, left arm, perfect. So we are really pleased that is getting done now. Good. Although Carly knows, and she wanted me to stress in her email that this does not change her behaviour. It does not change her use of PPE. It does not change her mask wearing. It does not change her hand hygiene. It does not change her social distancing. It does not change the way she ventilates her work areas. All that stays the same, and we're very happy to reinforce that. So always nice to finish on a little bit of good news, and that is us for today. I'm actually encouraged that so few people who have had the infection are getting reinfected. I'm particularly encouraged that people have had the infection and get reinfected and not sick. And I'm also encouraged that it looks like only 0.66% got reinfected in the study period from June through to November. So encouraging for long-term immunity, but we've got a long way to go yet, as of course you know. We've got this January and February to get over, I'm afraid, and they're going to be difficult. Okay, thank you for watching. Of course, great to have you.